may I request our chairperson to join us on the dais, Dr. Bikramjit Chakraborty, Senior Consultant Radiation Oncologist, Dr. Shubhadeep Chakraborty, Surgical Oncologist from Apollo, Kolkata, to please join us on the dais. The moderator for the session is Dr. Moses Arun Singh, who is a Senior Consultant Radiation Clinical Oncologist working in Tata Medical Center, Kolkata. Dr. Moses has been trained in a premier institute in India as well as in UK. And he has been my colleague both in India while I was working in Tata Medical Center, Kolkata, as well as in UK. So I'd request Dr. Bikramjit Chakraborty, sir, to introduce our moderator and the panelist and start the session.
Hello. Good afternoon, everybody. Please come inside who are outside. Today, excellent topics are being discussed in this conference, and there is much more to go. Now, the next topic of discussion where there is much more controversies, and there is excellent panel of speakers and the excellent moderator will discuss about the oligometastatic prostate cancer. Our esteemed moderator is Dr. Moses Arun Singh from TMC Kolkata. He is very well experienced and well trained and well known person in the field of radiation oncology. So I request Dr. Moses Arun Singh to start the session, please.
Thank you, sir. So let me invite all my panelists. Can I have the first slide on there, please? So we have a big panel. I'm not sure if everyone is available over here. I'm going to call out their names. We have 5 radiation oncologists, Dr. Ritika from Mumbai, Dr. Mukti Mukherjee, Dr. Jyotir, I think he's excused himself for today, Dr. Dipanchan Majumdar, Dr. Sthiti Das. Ritika, come up. And among the medical oncologists, we have Dr. Devleena Gangopatyay and Dr. Tanmoy Mandal. You can join us here. Surgeons, we have Dr. Amit Choraria. Is he here? He isn't here. So Dr. Tapash Kar, Dr. Anil Chomal, and Dr. Barun Saha. I think we need more chairs over here. Yeah, so wherever I go, the topic of oligometastasis seems to be chasing me. I'm usually given talks on oligometastatic lung cancer or oligometastasis in other sites. And the topic for today is a panel discussion on the treatment of oligometastatic prostate cancers. So the questions that we'll be discussing in this session are how do we diagnose and define oligometastatic prostate cancer? What is the optimal systemic therapy and role of prostate-directed radiotherapy and the role of metastasis-directed treatment? So before we go ahead into the treatment part, I just wanted to ask each of the panelists, how often do you come across oligometastatic prostate cancers in your practice? I mean, what percentage of metastatic patients that you see would you classify as oligometastatic prostate cancers? Each of the panelists can just quote a number that would help us to set the ball rolling.
Myself, Dr. Borun Shah, I am an urologist.
Yeah.
So to me, oligometastatic prostate cancer is a low burden metastatic cancer.
Yeah.
So it's about 50-50, low burden, and high burden is about 50-50.
Yeah. So any others, do we have a different numbers, or are all of us agree on a 50-50 separation among all the metastatic prostate cancers? Yes, okay. Right, so Just wanted to get to know from all of you, how would you go about defining an oligometastatic prostate cancers, and how do they usually define, so the different sites have different definitions of how we call an oligometastasis. How is it different in prostate cancer?
Most of the literature diagnosis is less than equal to 5 extracranial metastases.
Okay.
But should not be more than 3 in a particular organ, lymph node or bone.
Right,
Like
so that is the same definition that you would use for prostate cancer as well? Less than 5?
I usually follow that in the low burden,
Okay.
less than equal.
Any other difference of opinion from the others in the panel?
Hello. Yeah, I am Dr. Dipanjan. So first of all, there are a lot of discrepancies in definitions of the oligometastatic prostate cancer. But what most commonly it has been followed, because there are the number of metastatic sites has been different in different trials. But it is ranging from even as low as 1 to more than 5 even. But
Right.
I personally think that 3 would be the correct number, because some of the trials, it has been shown that they were less than equal to 2, or some of the trials, if there is the 4 bony sites or axial skeletal sites, involvement will be considered as a low volume disease. To me, 3 will be the optimum number to consider as a oligometastatic site, even if there is a high volume disease like a solitary visceral mates can be considered as an oligometastatic site. But still, I would like to restrict my definition to the bony metastatic site, I think.
So you would consider, even if there is a single met in a viscera as well, could be considered as an oligometastasis, even if somebody has just 1 liver metastasis and 2 bone
Yeah,
metastasis?
technically, if it is a single mates in the visceral site, technically it can be considered as oligometastatic site, but it will definitely be a higher volume disease.
So regardless of the
considering
site,
other,
you would go by the
criteria.
numbers. Any other difference of
So I
opinion?
think there are more than the number. There are other things also that we should consider. First of all, there are 2 brackets: synchronous oligometastatic versus metachronous oligometastatic. That's one. Then if it's a metachronous, what is the time to progression? So there are a number of factors that we consider when deciding treatments for oligometastasis. And then I think 5 is a reasonable number. There are people supporting more than 5, people saying less than 5. And then about particularly prostate cancer, I think we have some trials having certain criteria like the charted or the latitude having the low metastatic burden or the high metastatic burden based on the number of bony sites, visceral or non-axial involvement.
Right, yeah. Any others want to pitch in? Any difference of opinion?
I'll also add the same thing, just as Dr. Ritika said, that we are having certain criteria as per the charted, and we are having like risk factors for bone and visceral metastasis, and sometimes lesion scoring also. But what matters is also the volume of the metastasis and time to progression.
Right. So, yeah, so we'll come to the discussion of that. So, from what we have heard from the panelists, it seems the numbers matter, and the time at which the metastasis is diagnosed from the diagnosis of prostate cancers definitely matter, and possibly the sites where the metastases are present are also going to matter in defining it. How do you usually, what is the kind of staging that you do for your prostate cancer patients? Say if you got a initially localized prostate cancer, someone who presents with high PSA levels, what's the sort of staging procedures that you do? Consider that the local staging is all over. You are looking to rule out distant metastasis. What sort of imaging protocol do you all follow?
So in our practice, we first used to prefer do a MRI, multiparametric MRI.
The local staging is done. I'm talking about distant metastasis.
For distant metastasis, till now, the widely available modality in our city is the PSMA PET CT.
Okay. Yeah.
But it is not to that extent very much sensitive. If you go for choline PET CT, it will be better, but it is not available widely. So PSMA PET CT is in the city like Kolkata is a more acceptable method to.
So what sort of patients would you offer a PSMA PET CT scan? How would you select the patient? Which patient should get a PSMA PET CT scan and which patient wouldn't you offer it?
Look, what I was initially telling that in MPMRI, we usually do the MPMRI, do the local extension, and do the lymph nodal status in the pelvis.
Yeah.
And along with this MRI, we usually advocate technetium 99 MDP bone scan. So if there is widespread bone mets and darts, we just don't go for any PSMA PET CT.
Okay.
PSMA PET CT, usually we offer for them who have low extra prostatic extension and low pelvic limb adenopathy. Suppose one lymph node but less than 1.5 centimeter in the iliac lymph node, then in that case, where we are thinking there may be some scope for curative surgery or curative radiation therapy along with targeted therapy. In that case, we used to prescribe PSMA PET CT, or in a subset of patients in which previously who have undergone radiation therapy or radical prostate, in which there is PSA recurrence. In that scenario, we advise the PSMA PET CT.
So anyone with a suspected node in a localized prostate cancers and post-radical setting, if there is a recurrence of PSA, then you would consider PSMA PETs. Anybody else would do any other imaging apart from PSMAs? Anyone still doing CT scans, bone scans, or everyone has moved on to PSMA PET scans? Okay.
Can I just add one thing?
Yeah.
So this one of oligometastatic, I wouldn't probably even try to define, because even in specialists there are 7 different definitions.
Yes,
so I would go with low and high volume metastatic disease. That's the first
I'm coming
one.
to that, sir. Yeah.
And the second one is all the low and high volume is based on bone scan and CT
Yes,
or MRI,
yeah.
not on PSMA PET.
Yes.
The reason for that is PSMA PET is diagnostic, not prognostic. Bone scan is prognostic. And we have to differentiate that. Whenever we are saying low volume and using a PSMA PET, we know that we are already calling them high volume because it does pick up more.
Yeah. So I think the time that was earlier given to me was 30 minutes, so I'm going to skip some of the slides because it's been reduced to 20 minutes now. So I'm sure all of us know about the concept of oligometastasis. Like Dr. Adla just mentioned, there's no clear consensus on where we should draw the limit on what is an oligometastasis, even among the experts across the world. So like many of my panelists mentioned, when we define oligometastatic prostate cancers, it depends on the number of metastases, the extent of metastasis sites involved, and what sort of diagnostic modality we are using, the bone scan and the PSMA scan. Although we are more and more using PSMA scans for staging our prostate cancer patients, all these oligometastatic disease studies have all invariably used bone scans and CT scans for defining oligometastatic disease. We need to keep that in mind. And we mentioned about the latitude and the charted definitions. Most of the studies where people have looked at treatment benefits in oligometastatic disease have used this definition of charted, excluded the high volume and defined the low volume. So this is what we have used. But there are fallacies associated with this definition as well. Going by this definition, a patient can have any number of nodes, any size of nodes, and still be classified as low volume. Small visceral metastasis, like Dipanjan was mentioning, even if there is a single less than 1 centimeter lesion in a viscera, they would be excluded as a oligometastasis going by this definition. And yeah, so we've moved on to this, and what basically this does is introduce a Will Rogers phenomenon whereby you're just reclassifying a group of patients and putting them into different baskets and just patting ourselves on the back saying that we have improved the outcomes of the two groups, whereas you've just redistributed the patient and not really added any benefit to those patients possibly. And yes, as it was mentioned, for lymph nodes and bone metastasis, where there are doubts, possibly molecular studies are, molecular imaging is much more useful. Although we have all these definitions, if you look at this table, most of the studies have just used possibly what is technically feasible. These are all studies which are using radiotherapy to address oligometastatic disease. So they've just used whatever is technically feasible. I think they've just used a cutoff of 5. Whether that is the actual definition, time will tell. What we actually need is some form of biological definition which will help us to identify a proper oligometastatic disease. I think we've got one medical oncologist on the panel here. So, we've got 2, sorry. So does the choice of systemic therapy differ based on whether the extent of the metastatic disease?
If we are treating, taking it to account as a metastatic hormone-sensitive prostate cancer, then I think based on the high volume and the low volume, or the high risk or the low risk, the systemic therapy differs. But when we treat it as just an oligometastatic, suppose a prostate with a retroperitoneal node, that time generally we prefer to use the oral forms, either in the form of abiraterone or enzalutamide, to downstage and then go for radical radiation in those patients. So, but yes, when we are treating it as frank metastatic, it's better to treat with systemic if it's a high volume or a high risk disease. So even if it's a low volume but a high risk, means Gleason score is 8 or 9/10, then I would prefer to treat with docetaxel based chemotherapy.
So when would you use a doublet and when would you use a triplet? What is your
triplet, it's high volume, high risk, it's a triplet, docetaxel, ADT plus docetaxel plus the darolutamide, what we have it now. It's high volume, high risk disease, which if all other things are constant, we prefer to use triplet therapy.
Okay. Slides, it's not. The next slide, it is not going. Something is, this whole slide is missing. Yeah, so just continuing with the discussion, so like you mentioned, so you, for any high volume, you would prefer to use triplet therapy, and for any other patient, you would definitely offer doublet. Is there any patient whom you would not offer a doublet therapy? Is there a particular subgroup?
Not offer a doublet therapy means a very elderly patient, if the survival with multiple comorbidities, that patients might be offered only ADT alone. Otherwise, we would prefer to use any of the systemic agents in almost all the patients.
Right, yeah. So, yeah, this is just a slide to show that there was supposed to be another slide. For some reason, that slide is not working, which was just to show the benefit of doublet therapy, regardless of whether it is low volume or high volume. But when it comes to doublet therapies with androgen receptor pathway inhibitors, but when it comes to docetaxel, possibly it's just the high volume patients who benefit more from this. And now we have the triplet therapy as well. Again, here as well, we see that in both low volume and high volume, there was better radiographic progression-free survival, but the median OS was better in the overall high volume disease as of now. Just skipping. Prostate-directed therapy, we would like to know from both the surgeons and the radiation oncologists in the panel, which patients and which modality would you prefer? Is there a really role for surgery at this point of time? Yeah, surgeons can take it first.
First of all, going for radical prostatectomy, we have to evaluate the baseline patient's comorbid status, patient urinary function, bowel function, and sexual function, and his life expectancy at the time of diagnosis. If it is a younger age group patients, 55 to 60, who have a good life expectancy of more than 10 years, then only we consider a radical prostatectomy, be it be localized or this oligometastatic scenario. So the patients who is less comorbid illness, who is going to survive for another 10 to 15 years, then only we should consider for radical prostate in this group of patients. Otherwise, the patients who have already have metastasis, I will not go for them for any radical prostatectomy with the known factor that he has already undergone metastasis.
The other surgeons in the panel, if you want to add something.
I think prostate-directed therapy is like there are only certain studies and trials, but not all the things are validated, like the SWOG trial, the TROM1 trial, where we have seen that cytoreductive surgery in radical prostatectomy if you are doing, that decreases the disease progression to a certain extent, and because there is less of seeding and of the tumor cells. And with the advent of robotic surgeries, I think the complication rates have also come down if you consider radical cytoreductive prostatectomy.
Right.
But there are certain criteria that the number of bone mets should be less than 3,
So
young patient.
You would, I mean, as of now, the evidence is limited, but
Limited,
you may,
it's
you
not
may
validated
choose.
as of
Okay,
yet.
all right. So you want to add
Same
something?
thing that in younger patient with a good life expectancy, with less comorbidities, with low volume disease, we discuss with the patient, and if the patient opts, then we can go for surgery. Otherwise, we will go for
Thank you, sir.
radiotherapy and
Can add prostate-directed therapy for radiation in less than 3 mets. Because
Okay.
we have seen in Horat's trial and Stampede trial that the subgroup analysis showed that there is a overall survival benefit as well, along with the progression-free survival,
Yeah.
with equal side effects around grade 2 toxicity.
Right. So regarding surgery, as both the panelists rightly mentioned, limited evidence. So there are these phase 2 trials going on. We'll have to wait for the evidence of those to see if surgery can actually be offered. And with regards to radiotherapy, definitely there is evidence from the Horat trial, although it was just only a trend towards benefit in patients who had less metastasis. But the strongest evidence comes from the Stampede subgroup analysis, where you have a better overall survival in the low metastatic burden as defined by the Charted trial. And this was a secondary analysis of the Stampede trial again, where they just simplified the low volume by saying that just 4 or more bone metastasis. Then again, they saw that there was a benefit for prostate-directed radiotherapy. And earlier it used to be argued that this was only a trial where only single agent androgen deprivation therapy alone was done. But now we have evidence from the PEACE one to say that there is, even in the setting of doublet and triplet therapy, there is still a role for prostate-directed radiotherapy. Several endpoints like radiographic PFS, castration resistance-free survival, and the time to serious genitoourinary events all were better with prostate-directed radiotherapy. Lastly, I'll take 5 minutes extra. Metastasis-directed therapy. Again, which patients do you offer such treatments? What modality would you choose? Radiation, surgery, intervention, radiology? And do you offer systemic therapy along with that? And if so, for how long?
So basically, metastasis-directed therapy is applicable only in low-volume disease patients. Otherwise, the systemic therapy is what overpowers. So low-volume disease patients where there are lesions which are amenable to a local surgery or radiation therapy. In terms of radiation therapy, we generally offer saber or ablative doses in 2 to 4 fractions, 2 to 5. And the duration of systemic therapy, generally one of the reasons to add saber is to delay the change of line of systemic therapy or the ADT freeze time that has been even shown by some of the trials like STOMP. And the pelvic nodal recurrence after radical therapy, so that depends what radical therapy we have given in the past. If it's a surgery, then radiation can be.
Surgeons, regarding the pelvic nodal recurrence, do you routinely come across this situation? And if so, would you offer salvage dissection?
Yeah,
for such
there is
patients?
always a scope for lymph node dissection. I mean,
as she told, low volume disease, and we have to see what earlier therapy has been offered. So there is always a scope. Again, as it's like nothing is, there is no RCTs, or all are limited trials and studies.
Yeah. I'll show you the evidence before we go on. Last question to the
But
medical.
there is definitely a increase in overall survival.
So last questions to the medical oncologists in the panel. The duration of systemic therapies. Some of the trials which have tried to salvage by doing metastasis-directed radiotherapy, they use a shorter term duration of ADT, but generally in a metastatic setting, you would, once you start, you just continue, isn't it? So if someone is receiving a salvage radiotherapy, would you opt to give a shorter duration of ADT and wait for disease to progress later on, or would you prefer to just
So what we
continue?
do is generally when we see that prostate with a retroperitoneal node and we stretch it, we call it as a locally advanced, or it's basically a oligometastatic, but we call it as a locally advanced. And for that subset of patients, generally that 2 years of abiraterone and 3 years of ADT is what we do. Means it's just a locally advanced one. But yes, if it's a frank metastatic disease, I would prefer to continue the systemic therapy as long as possible along with the ADT.
Right, yeah. So this is one just systematic review which showed most of these studies have been done in the recurrent setting, where it was possible to salvage by giving either radiotherapy or lymph nodal dissections. And some of them have also used androgen deprivation therapy with either of these therapies. And that has shown a progression-free survival. Whether it ultimately results in an overall survival is still debatable. And this is the STORM trial, where if 3 or 4 mets were there, they gave radiotherapy to these or did surgery for the metastasis, and this was against surveillance. What it showed was doing metastasis-directed radiotherapy allowed you to delay the start of the ADT. And similarly, this one was with just radiotherapy, the Oriole trial. Again, here, the use of SBRT for the metastatic sites allowed you to delay the start of androgen deprivation therapy. This is the pelvic recurrence oligopelvis, which is now being presented, where they used a short-term duration of ADT along with whole pelvis radiotherapy with a boost to the nodes. And this was in patients who received radical radiotherapy and prostatectomy in the past. And there was a definite improvement in PFS and biochemical recurrence-free survival with such an approach. Yeah, for want of time, I had to rush through many of the slides, but I think, yes, sir, yeah.
Radiotherapy being directed to the metastatic site along with the primary. We give radical radiation to the primary site and leave the metastatic sites for the systemic treatment. But
So,
how is the evidence?
As of now, the prostate-directed radiotherapy is where all the phase 3 evidences are for, and the adding metastasis-directed radiotherapy in addition to the systemic therapy is all being evaluated in trials. Whatever I have shown now were all in the recurrent setting, where the use of metastasis-directed radiotherapy has allowed you to delay the start of ADT. As of now, doing both PDT and MDT along with systemic therapy is not the standard of care.
So there is one study at least, there is one study in which in the metastatic prostate and breast cancer, for the high risk lesions, I mean if it's likely to cause complications, now they added RT to them prophylactically.
This was in a bone metastasis setting, yes.
And in that they prevented the skeletal related events and also led to an improvement in survival.
Yes, I think this was recently presented in one of the conferences where
So
they prophylactically irradiated all the bone metastasis, and it was shown to prevent skeletal related events, as similar to the benefit from zoledronic acid, I believe.
So that also, and also in metastatic first line prostate cancer, now with bone metastasis, in the hormone sensitive prostate cancer, usually we never used last couple of years, any Joledronate or anything, because they did not reduce skeletal related events or survival. But now there is data to show, at least if you use even in metastatic hormone sensitive prostate cancer, there is a reduction in the fracture related hospitalization.
Yes, yeah, this was also recently presented that previously addition of zoledronic acid in hormone sensitive used to be a non-standard approach, but now there is evidence that it does improve the bone health even in patients with hormone sensitive prostate cancers.
And I think also we can consider data from Sabre Comet. I mean, it did include patients with prostate cancer.
I didn't put it up because it has been highlighted in almost every conference, and that is not specific to prostate, it was all comers.
Yeah, so but then that has shown that metastasis-directed therapy has a role.
And Sabre Comet 10, which included the 3 to 10 Mets, have completed recruitment as well, so we should get the evidence from a phase 3 trial as well in the nearer time, yeah.
So when a patient comes with upfront metastatic disease, oligometastatic disease, so you are planning for systemic therapy and prostate-directed radiotherapy. So what should be the ideal sequence?
So if you look at the PEACE-1 trial, where the triplet therapy was done, and in the STAMPEDE trial as well, about 20% received docetaxel. So all of these patients get initiated on ADT. And in the STAMPEDE trial, some of them even received radiotherapy within 1 year after randomization. So that means they had received ADT for nearly a year before they ended up receiving their radiotherapy. And in anyone who is going to be offered docetaxel along with that, they've all been given radiotherapy after the docetaxel was completed, both in STAMPEDE and as well as in PEACE-1.
Thank you. Thank you, Dr. Moses, for an excellent moderation on oligometastatic disease, prostate. It's a simple way you have explained, and I will also thank all my panelists. It was a very nice, lucid discussion. We can keep on talking to the end, but this is paucity of time. We will shift to the next topic. Thank you all.
Thank you so much, and thanks for all the panelists.
Just before we conclude the session, may I request our chairperson to hand over a memento to our moderator, Dr. Moses Arun Singh. And just after that, we'll have a group photo with all the panelists. So can we have a group photo with all the panelists and chairperson together? Thank you.